So examination of the shoulder joint, we'll have a quick run through and then we'll go into some of the more detailed points subsequently. So first thing I need to do is expose the patient. So can you take your shirt off for us, please? And as he's doing that, you get a good idea about how mobile he is, how comfortable he finds that movement. It also gives you an opportunity just to make sure he's not got any obvious slings or splints, and have a quick look at his hands. There's no obvious signs of a systemic arthropathy such as rheumatoid arthritis. So we'll begin with inspection. So inspection from the front. I note that he's holding his right shoulder slightly lower than his left, which is normal for a right-handed man. He has a normal contour of both shoulders. They're symmetrical. There's no obvious wasting or squaring off of either shoulder. His clavicles appear symmetrical. His AC joints are not particularly prominent. And there's no obvious scars or swelling. Can you turn and face that way now, sir? Looking from the side. Again, no scars. You've got to look quite hard for arthroscopy scars. He's got a normal cervical lordosis. And again, there's no obvious wasting, no obvious winging of the scapula. And face away now. And looking from behind. Symmetrical trapezius. No obvious scars, and specifically check in for supraspinatus or infraspinatus tenderness, wasting, and that's all fine. Just turn and face me now, sir. And finally, just to double check for any scars or swelling in the axilla, which you can miss if you don't specifically look for it. Now we need to move on to palpation. The shoulders are largely a subcutaneous area, so we can get a lot of information. So feeling over his sternoclavicular joint, no tenderness there. Clavicle is normal and non-tender. AC joint, normal and non-tender. Acromion, normal, non-tender. Lateral to the acromion, over the greater tuberosity, is non-tender. The back of the shoulder joint, back of the acromion, sorry, is non-tender. Posterior joint line, non-tender. Coracoid, non-tender. Anterior glenohumeral joint, non-tender. Feel for his biceps tendon, which can be difficult if they've got well-developed deltoid. That's non-tender as well. Now we need to move on to movement, and it's nice to start with a quick screening manoeuvre. So can you just pop your hands behind your head for me, sir? And up your back. And with your right hand, try and stretch the back of your left shoulder. That's a quick screening test, and clearly it doesn't seem to have any obvious restriction there. But let's be a bit more formal about it. So it's quite good with the shoulder to get the patient to copy you. So if you put your hands face forward and put your hands right above your head. That's it, that's full active elevation. Nothing further to add passively. And bring your arms down. And he brings it down nice and smoothly. There's no obvious painful arc or drop arm sign. Now we'll do that with you bringing it forward. So if you face that way now, sir. Now I want you just to take your arms forwards, right above your head. And down. And again, full 180 degrees with no significant winging of the scapula. Okay, now face us again now, please. And now put your elbows at your side and turn your hands out as far as you can, keeping your elbows in. So he's got active external rotation of about 60 degrees, nothing further to add passively. Now turn and face away from me, sir. And now can you put this hand up your back as far as you can? You can bring his thumb up to between his scapulae, that's around about T6, which is normal. That's great, now that's fine, turn around and face me. If you've identified any problems with shoulder elevation, initially I think it's very useful to then go back and do it from the behind. You want to look specifically at the rhythm of the shoulder and the glenohumeral and scapulothoracic motion. So if we just do that, just for demonstration purposes. So if you face that way, now I want you to raise your arm above your head as you did before. So he has a normal rhythm and come down. There's no jerkiness, it all flows smoothly. To clarify the movement and what proportions coming from the glenohumeral joint and from the scapulothoracic joint, you should try and stabilise the scapula. You can either do that by placing your hand over the top there or by feeling the angle of the scapula at the bottom. And then you ask him, can you abduct your arm now? And now I can feel his scapula wants to move. So he has 90 degrees of glenohumeral abduction. and then the scapula wants to move, and that's again normal. Okay, turn around and face me. Now we need to test his rotator cuff. First thing I want to check is his supraspinatus. So if you can bring your hands and your arms forwards and in the plane of the scapula and turn your thumbs down and hold that position there, push down, and he's got good power in his supraspinatus. Now put your arms at your side like that and push out against me with your hands. Good power of infraspinatus. And now if you could just turn and face that way and pop your hand on your lower back, and bring your hand away from your back and hold that position there. Is good power of subscapularis. That's fine, and turn and face us now. We ought to just do a few special tests. So if they've got subacromial impingement, you want to do the Hawkins-Kennedy test, where you abduct the arm across the chest in elevation of 90 degrees, internal rotation, and looking for pain, and that is not painful. And then similarly, we can stress the acromioclavicular joint by doing the crossed arm adduction test or the scarf test, and that's not causing him any pain. We can also check for winning of the scapula and a whole host of other things, but we'll come on to that in the next part of the video. Finally, we want to finish with examination of the neurovascular structures. Main neurovascular structure we're worried about really is the axillary nerve, which is the one most commonly injured in shoulder injuries. We've already commented his deltoid is not wasted. Any numbness there, sir?
No.
Same both sides?
Yes.
And put your arms up like that for me and hold it there. Good power, that's fine. And then quickly check the rest of the major nerves in his arm. So any numbness in your thumbs?
No.
Or little fingers?
No.
Turn your hands over and over the backs there. Is that all right?
That's fine.
Okay. And then I want you to point your thumbs up at the ceiling. Hold it up there. Spread your fingers wide. Turn your hands over and cock your wrists up. Just do that. There. Good, that's fine. And then feel for a pulse. And he has a good pulse. Finally, I think I would offer to examine the patient's neck, as it's quite common for patients with shoulder pain to actually have some cervical spine pathology. And you could also go on and do a detailed examination of the brachial plexus and possibly even the chest if you think that's the source of the patient's pain. So that's basic examination of the shoulder joint. I'd like to introduce Alison Edwards, who's one of the upper limb consultants here at the University Hospital. Alison, could you just firstly talk a bit more about examination of the rotator cuff, specifically what kind of abnormal signs we might see, and then tell us a bit more about examination of the other muscles around the shoulder girdle.
Yes, let's go into a little bit more detail examining the various muscles of the rotator cuff and other muscles in the surrounding area. First of all, you may notice when somebody's attempting to abduct their arm, if they have a deficient rotator cuff, they may demonstrate what's called a hitch sign. So if you could abduct your arms to the side for me. And in this case, you'll notice that our model's demonstrating that he's using his trapezius to bring his shoulder, his deltoid muscle in order to then continue to abduct his shoulder. And this is usually because supraspinatus is not initiating or helping deltoid in the early stages of abduction. In terms of a painful arc, you could abduct your arm to 90 degrees for me. A painful arc from supraspinatus type impingement usually begins around 80 to 90 degrees. And abduct further. Once one reaches about 120 degrees, it's the AC joint which is compressed, and so where pain is experienced in the upper part of the arc, that's called a high arc, and that's usually the AC joint involved. Bring your arms down. The AC joint can usually be distinguished from supraspinatus impingement by performing the scarf test. You bring your arm across. In this case, the AC joint is compressed anteriorly. You relax your arms down for me. The other things that might be involved in rotator cuff injury are the long head of biceps. And on inspection, it's sometimes easy to see an area where the outline of the muscle at the top of the biceps is lost. In some cases, the pec major muscle may be lost from its attachment onto the proximal humerus, although this is usually a separate injury to a rotator cuff injury, but is common particularly in weightlifters, etc. And in that case, the anterior axillary fold is usually lost. The integrity of pec major can usually be assessed if you put your hands on your hips for me and push in. And this tenses the pec major muscle, and its outline can easily be seen. Relax. In someone in whom the pec major muscle has gone or is partially torn, there's an obvious bunching of the muscle up towards the chest. Testing the integrity of the long head of biceps can also be done. If you straighten your arm out in front of you and don't let me push down. And the long head of biceps can be felt in its groove here. If pain is experienced but there's no evidence of a rupture, that may indicate some biceps tendonitis instead of a rupture. The other muscle, which is less commonly involved in rotator cuff pathology, can be assessed by the hornblower sign, which is where the arm is abducted and then externally rotated against resistance. Don't let me push down, and that's teres minor. It would be an unusual eventuality for a teres minor muscle, or indeed infraspinatus, to be separately ruptured without supraspinatus pathology. Testing the infraspinatus muscle, if you flex your elbows up in front of you and externally rotate, that's the normal action of infraspinatus, and it can be tested against resistance. In some cases, the arm will come out naturally, but then can be easily pushed back in with the patient able to generate little or no resistance against you, in which case infraspinatus is most likely torn. We can move on then to testing for some laxity or instability tests. The shoulder is an area of the body where instability or laxity is often demonstrated. We're going to talk a little bit about the Baton scale, which demonstrates whether or not someone has hypermobile joints. And this involves testing the hands, looking at how much hyperextension can be obtained at the MCP joints. Is it over 90 degrees? Can the thumb be brought around to the forearm? And that's one for each side of each of those tests. Do the elbows hyperextend beyond about 5 degrees, which is considered normal? You turn around, face sideways, and lock your knees back straight. Is there hyperextension at the knee joints? And turn back and face forward again. Can the individual bend forwards with their legs straight and place their palms flat on the floor? And up. The maximum score is 9, and a person is really considered to be hypermobile if they score more than 5 out of 9. When looking specifically at the shoulder joint, the first test we can perform will look at whether or not there is any significant laxity in the shoulder joints by pulling down and looking to see whether or not a sulcus sign is generated beneath the acromion through the humeral head being drawn down. In this case, there's no sulcus sign. In someone who's relatively heavily muscled, it would be unlikely that you'd be able to see a sulcus sign, but it's a very common sign, particularly in young females, and may be normal for them. So we'll move on now to performing some stability tests for the shoulder, and for this we're going to put the patient onto the examination couch. Put your legs up. So I'm going to rest my hand on top of the acromion, and I'm going to feel where the humeral head is and see what amount of antero-posterior movement there is within the humeral head on the glenoid. In some cases, when someone's very hypermobile or has an unstable shoulder, it may be possible to push the humeral head almost completely out of joint. And you can also tell whether someone has any significant posterior laxity as well. So looking for anterior instability, we'll check for apprehension on shoulder abduction. So I'll place my left hand on top of the patient's acromion, abduct and externally rotate the arm, and this will often generate a feeling of discomfort or worry in the patient that the shoulder is going to dislocate. By placing the thumb in the back of the glenohumeral joint, one can then apply additional anteriorly directed force to move the humeral head forward on the glenoid. And in someone who's very unstable, the shoulder may indeed dislocate. The shoulder can then be relocated by anterior pressure on the humeral head directed posteriorly in order to push the humeral head back in and internally rotate the shoulder. In order to test posterior instability, we usually need to have someone lying down flat. And these tests are best performed on an anaesthetised patient. In order to test for posterior instability, it's best to bring the shoulder up to 90 degrees, and a posteriorly directed force with the arm forward flexed will often cause the shoulder to clunk out posteriorly. This can be done in an adducted or a straightforward position. So now we're going to look at winging of the scapula. There can be a number of different causes of winging of the scapula, which may be neurological, muscular, or indeed simple pain inhibition of function. But first of all, we'll look at what winging actually means. If you could turn around and face the door for me. Just relax your arms down by your sides. When one looks at the posterior aspect of the chest and the thoracic muscles, they should be symmetrical. In someone with a winged scapula, you may see the inferior border of the scapula lifted out in comparison to the opposite side, and the muscles in the inferior part may be more obvious. It may be that it's more the medial border which is winged, in which case the rhomboid muscles tend to be more obvious, but what you will notice is an asymmetry of the two sides, and it's then more easy to find out which side is the abnormal side by asking the patient to do a number of manoeuvres. If I could ask you to extend your arms out in front of you and press on the door, lean forwards, and now push yourself backwards. And relax down. And in a normal case, the individual's muscles will work the same on both sides, and if there's an abnormal side, the scapula will appear retracted back from the chest wall. In that case, there may be some dynamic winging. If it's obvious when the patient is simply standing in front of you, then it's static winging. It's difficult to tell the causes of winging without performing some additional neurophysiological tests or other tests of the musculature involved.
So that's great, Alison, thanks for that. So hopefully we've managed to show you all the common tests that we'll use around the shoulder joint. Of course, there's any number of other tests that the books describe, but I think if you're comfortable with everything that we've shown you today, then you should have no problem in the exam.